Okay, I think we can start now. Assalamu alaikum and good evening, everyone. First, I would like to thank all of you for attending today's educational webinar. Now, today is another day where we'll continue our commitment, support for the educational programs, especially for the healthcare providers in Saudi Arabia. And for today's events or the educational events, we will cover a very important side of the blood gas testing. And we would like to highlight more about the pre-analytics practice and its impact on the blood gas testing. I'm sure all of you are aware of this topic and the importance of this topic. Just to give you a brief about the team members who's joining us today, let me start with myself. My name is Abdulla Attili. I'm the product manager for the acute care lines in Werfing Company and covering the Middle East and Turkey, west of West Asia. And here with me, my colleague, Mr. Mohammed Nafadi. He is the product manager as well for the acute care based in Saudi Arabia. And he is from our partners, Abdulla Fouad Company, whose partnership, they have partnership with Werfing Company. And so I hope today you will enjoy this session, which is more focused on the educational session and to have more interaction. And feel free to have any questions or you want to share thoughts. You can see in the chat box or the question and answer box. So to get started with today's webinar, first I would like to thank Mr. Tariq Jasser for joining us as the moderator of this educational event. And as most of you know, may know, Mr. Tariq is the head of Department of the Respiratory Care Services in King Faisal Specialized Hospital and the co-chairman of the Medical Gases Committee in the King Faisal Specialized Hospital as well, and the coordinator of Home Mechanical Ventilation Committee in King Faisal Specialized Hospital. So thanks again for Mr. Tariq, and the floor is yours, Mr. Tariq. You can have better, let's say, introduction and better start for today's event.
Thank you very much, Abdullah. I thank all the participants who joined us today. This is a rather an important topic that is frequently encountered in our daily work, whether it's on the laboratory work or on the clinical clinicians work, or even from nursing, from allied health, from respiratory, from laboratory. It's an important things because of the point of care testing, which the blood gas is one of the major elements of it, is became a critical and important tool in day-to-day healthcare, where it's always a decision point for health, for like medical teams and for surgeons, and whether it's in the operating room, in the clinic, or in the RRT, or in the sepsis team, or in the dialysis clinic, or in the ICU, or in the even more recently, and to some degree, to some patients, even at the community or at home, where you can make some decisions about the patients. Today, the Saudi Society of Clinical Chemistry, in cooperation with the Saudi Point of Care Testing Association and also Abdulla Fouad Company, is organizing this educational webinar that is titled "Improved Pre-Analytical Practice for Blood Gases and Related Analytes." The webinar is an important topic, as I mentioned, for all healthcare professionals associated for blood gas testing and critical care diagnostics, aiming to enhance healthcare practices across the point of care settings. Our core objectives in this presentation is to deliver usually more details of information about the best practice and procedure that mitigates the error that may occur during the sample collections, with deeper look over the limiting steps of our roles. Without further ado, I would like to everybody to join me in welcoming our main event speaker, Mr. John, who comes with great experience in this specific topic. Mr. John.
Thank you, Mr. Tarek. Good evening to all. That's my pick there, and I, as a presenter, I have a very long history in blood gases. As I mentioned to my colleagues here, I started in respiratory care in 1973 while I was in graduate school. Much of the information that comes in this presentation is not only from the literature, but my own experiences and the experiences of my staff in reporting erroneous blood gases that we later determined were due to our handling practices. So this presentation has evolved over several decades and includes our own personal experiences as well as literature and information from regulatory agencies. Now, currently, I'm a senior clinical consultant for Werfen. Werfen is the company that manufactures the instrumentation laboratory blood gas analyzers. I formerly was the director for many, many years of a large hospital, suburban hospital in metropolitan St. Louis, Missouri, where I was director of respiratory care and several other departments. In that aspect, I was also involved in many educational seminars, both in the United States, Canada, and actually worldwide in many, many venues. So I've done a lot of presentations on pre-analytics. I've also co-authored chapters on blood gases in several editions of a clinical chemistry book, as well as written many articles for mostly involved with respiratory care. So that's my background. So improving pre-analytical practices for blood gases and related analytes has been noted as the title of the topic. Blood gases, by necessity, require whole blood sampling. Most laboratory tests use plasma or serum to prevent the issues from metabolism from the cells. Whole blood, as you know, is a living tissue. It continues to metabolize after the blood is taken from the body. It also continues to exchange gases. That's what red cells do. They exchange oxygen and CO2. So many of the practices that we use to prevent error are aimed at preventing these post-draw changes in samples. And as you know, blood gases are probably the most important test for critically ill patients who we are supporting for cardiopulmonary deficiencies. I will cover some of the most common errors and the best practices that help prevent these errors so that we don't cause problems for our patients. The disclosure statement, as mentioned earlier, I am a Werfen employee. Here are the learning objectives. Define the common source of pre-analytical error in blood gases and related analytes. It is very important in blood gases to understand that, we now have these full menu devices that not only report pH, PCO2, PO2, but also report electrolytes, metabolites, and co-oximetry. So handling practices have to take into account the ways that we handle the samples to reduce potential errors in all these samples. And it's so important that we do this because we know that acid base and electrolytes in particular are linked and related. For example, patients with ketoacidosis, diabetic ketoacidosis, very often will have acidosis and a linked and related hyperkalemia or high potassium. If, for example, that sample has a microclot that settles on the potassium sensor, it is very possible that we would be reporting an erroneous potassium value and not be aware that the dysarrhythmias caused by those high potassium levels are related to the high potassium levels because it looks like a normal potassium. just to give you an example. Recognize the potential for microclots to affect the accuracy of blood gases. I will discuss a study, a very well done study that shows the actual effect of microclots on sensors. Blood gas analyzers sensors have become much smaller over the decades. They are tiny, and I'll show you a slide that depicts exactly how small these sensors are. So even a tiny microclot, if it settles on a sensor, can alter the values. And finally, and probably the most important part, is to describe practices that reduce the potential for pre-analytic error. So as mentioned, the title is Improving Pre-Analytical Practices for Blood Gases and Related Analytes. So when we talk about these pre-analytic errors, we look at it in a larger picture at the cost of medical errors. In 1999, the National Institute of Medicine in the US, which is a quality organization for healthcare, estimated that medical error accounted for approximately 99,000 deaths at a cost of $17 to $29 billion annually. Since this study, there have been many other studies that have seemed to come to the same conclusion and have revealed even higher costs. This study really kicked off a whole realm of improvements for healthcare in the United States and Canada and the rest of the world. We have recognized that there are issues with medical care related to erroneous treatments of patients and diagnostics. In 2006, Nell and his colleagues also estimated the economic costs a bit higher at 282 million. This took in the considerations for lost time and ongoing damages to these patients. We also have recognized that up to 80% of medical care decisions are based at least in part upon laboratory results. And our patient population, the critically ill and acutely ill patients, blood gases are an extremely important component of the laboratory record. So when we talk about pre-analytical errors, we look at the total possibility of impact of errors from all three: pre-analytic, analytic, and post-analytic. However, pre-analytic is the most common source of error, accounting for up to 75% of total errors. So, which leaves a very small portion for analytic and post-analytic. So that's the emphasis of this presentation. An estimated 26% of these errors have detrimental effects on patient care and cost from inappropriate treatment. Obviously, if we act upon an incorrect value, we can cause an inappropriate treatment to a patient with unnecessary retesting, blood draws, or treatment charges. And it very often, when we doubt a result, or if we have acted upon an erroneous result, it will delay the appropriate care. And all this can increase the length of stay, certainly decrease the patient experience, and lend to caregiver frustration. So the main components that I'm going to talk about are specimen collection and specimen transport. And the final study that I'm going to relate to is that on average, costs related to pre-analytical error represent 0.23 to 1.2% of total hospital operating costs. For a US hospital with 650 beds, that's slightly larger than the hospital I worked at, is approximately $1.2 million. So a significant economic cost just from pre-analytic errors. So when we talk about pre-analytic errors, of course, you know, we're talking about the potential for these errors to be expressed in acid base and oxygenation, as well as electrolyte co-oximetry and metabolite, because we require whole blood samples for blood gas analysis, and of course they have to be heparinized. Results are often used for critical care and require a very rapid turnaround time. We've all been in ED when the patient comes in and we don't exactly know what's going on, but we know they need help. And we have to have the correct values to treat that patient appropriately. So pre-analytical errors can occur from gas exchange, in other words, leaving in air bubbles in a sample. In some cases, we don't even know the air bubbles are there. It has been shown that samples transported through pneumatic tube that have had small air bubbles purposely left in the sample, by the time the sample gets to the laboratory, that air bubble has been totally absorbed by the sample, and there's no evidence of an air entrapment in that sample. So it's very important to remove air bubbles. And I will discuss how that can affect the samples. Microclot formation, I will discuss that at length. Microclots can cause many issues. Post-draw metabolism, as mentioned earlier, blood is a living metabolizing tissue. It continues to metabolize after the blood is removed from the body. When we have a blood gas ordered, or when we draw a blood gas, we want the values to represent the state of the patient at the time of the draw, not what happens to that sample after the draw. So many of these pre-analytic practices are focused on preventing those post-draw metabolic changes. Line draw contamination. In the US and North America, approximately 50% of blood gas samples are now drawn with lines. As you know, lines have infusion solutions to keep the lines patent. If an inadequate amount of infusion solution is removed prior to the sample draw, it will affect the samples. And I'll give you some guidelines on how and how much waste sample should be drawn. Improper storage and transport. For the first decade of my practicing in respiratory care, we iced every sample. And that thought was good because we thought icing would reduce the metabolic rate of that living tissue, and certainly it does. But later on, we found that icing can actually alter the values, particularly potassium and PO2. So I will discuss that as well. And transport, of course, pneumatic tubes are not a great way to send blood gas samples. And there are other factors such as steady state time, or the wait time after a ventilator or oxygen or CPAP or PEEP change is made. So appropriate sample handling can greatly reduce the potential for pre-analytic error in blood gases. In 2011, Dr. Paul D'Orazio and his associates published a paper on the effect of microclots. Improper mixing of blood gas samples can cause microclot formation. And here are some of the conclusions from that studies. Most sensors are affected by microclots. The error magnitude exceeds TEA, which is total allowable error, and can impact clinical decisions. If not cleared, microclots can affect subsequent sample results. Let me say that again. If not cleared, microclots can affect subsequent sample results. In other words, a microclot that was left in a sample pathway from a previous patient, if it's not detected, it can affect the results of samples from other patients that follow an analysis cycle. Most blood gas systems cannot detect microclots until a scheduled quality control is performed, if they can be detected at all. We can all see a clot in a blood sample. It's obvious. Microclots, on the other hand, are not visible to the naked eye, so we cannot see that, and that's where we rely on analyzers to detect that. If you take a look at the graph, the way this study was done was that they treated samples to give values along the whole array of measurement values for all the analytes. So they would tonometer, that's where they add gases to give a varying values for pH, or for PCO2 and PO2, or they would alter the pH, electrolyte values, metabolite values on samples. Then they would split those samples, and one set of samples would be heparinized adequately, and the other set of samples from those same syringes would have clot producing chemicals added to them. Then they would compare the results on two sets of analyzers. And this example shows pH. On the vertical axis is the bias, or the difference between the clotted sample and the control sample. And on the horizontal axis, you see the range of pH values on the control instruments. In other words, the non-clotted samples. So I draw your attention to this upper triangle here, which shows a bias of greater than 0.2 in pH units at a value of less than 7.1. So think about this clinically. So here's a patient that has a pH of less than 7.1, but because of the microclot, the value would be reported at 7.3 or higher. We would certainly treat that patient differently if we knew that patient had a pH of less than 7.1 as in comparison to a pH of greater than 7.3. So that's just an example of how microclots can affect the results. Further, the study showed that pH values had a range with microclots, had a range of 0.02 to 2.0 pH units. For PCO2, minus 57 to 7 millimeters of mercury differences. For PO2, 10 to 110 millimeters of mercury. So if you look at the table on the right there, it shows the number of microclots or samples with microclots that exceeded twice the allowable error. It was considered that twice the allowable error was clinically significant. So for PO2, 17 of the 19 samples had errors that exceeded twice the allowable error, and down through the list, PCO2, 10 of 17, pH 7 of 14, etc. So virtually all samples were affected by microclots. So microclots can be common, and I'll show you some data on that, persistent or transient. In other words, they can wash away and they might not be detected. Microclots and or fibrin strands are very small and not readily detectable by operators. In other words, you cannot visually detect microclots. They can and do result from improper sample mixing, and I will talk about best practice for sample mixing. They can deposit on membrane of microsensors and alter sensor response. They can remain on sensors for multiple sampling cycles or transfer to other sensors, and they can be transient. And they can certainly alter values, as you saw from that study, if they're not detected. So immediate and effective mixing can reduce microclot formation. So the GEM 5000 uses a continuous cycle, 24/7, 24 hours a day, 7 days a week, of 5 quality checks to help ensure accurate results. And I'll show you some studies from what we were able to determine from GEM 5000s with IQM2. So system checks ensures function of all the vital systems, such as the pumps, the sample pumps, and the process control pumps, the aspiration method and probe, and for each sample analysis to assure that the sample was aspirated correctly. Then there are sensor checks where 5 levels of process control solutions are analyzed to determine that the sensors are operating correctly. Then there's introspect checks, which is new, which actually checks the samples during sample analysis, the last 15 seconds of the sample analysis during the last part of equilibration. The sample curves are checked to ensure that there is no contamination from microbubbles, microclots, or interfering substances during the sample analysis. If an abnormal curve is detected, introspect will flag it and will not report results on that particular sensor. Then there's pattern recognition checks, which checks primarily for interferences and microclots after the sample analysis. And then there's process control stability checks, which check all the process control solutions to assure that they are stable and reliable through the life of the cartridge. So microclot error detection study using intelligent quality management was published in 2017. The GEMS record all the sensors values for both the patient samples and for the process control quality checks. So they checked data from over 228,000 blood gas samples, and they saw that microclots were detected in approximately 700 samples, which is about a 0.3% rate. And typically the microclots were only on a single sensor on these samples. So if you think about that, that's 3 samples per 1,000 that if the microclots hadn't been detected, then erroneous values could have been acted upon for those patients. That doesn't sound like a lot, does it? 3 in 1,000, but if you do 10,000 blood gases a month, 120,000 a year, you can see that that number becomes very significant. These samples could have been reported with erroneous values. I point your attention to the middle graphic there, which shows a GEM Premier 5000 sensor card. The circles are the actual sensors, and as you can see, it's an approximately a 30 millimeter card. So the sensors are approximately 1 millimeter in diameter. The image on the right shows a graphic depiction of how microclots could settle on a sensor and subsequently affect the values. There were 3 studies done in various hospitals throughout the world with various operators, and they came up with very similar results from microclots. So microclots post-analysis range from 0.2 to 0.5%, and transient errors, where it's picked up only with introspect, that's during the sample analysis, range from 0.1 to 0.6%. So the overall rate on this 550,000 plus samples was about 0.8%. And if you look at the gross numbers on that, that would mean that there would have been 4,600 samples reported with erroneous values if they had not been detected due to the presence of microclots. So let's talk about improving pre-analytic practices for blood gases and related analytes. The way this presentation is set up is there's a challenge slide, typically followed by a solution slide. The challenge slide shows what specific problems can occur in blood gas testing, and then the solution slide does what it just says, it gives solutions. So it kind of follows the path of the sample from the patient to the analyzer. So the first problem is air contamination, bubbles in the sample. If you draw a capillary sample, a venous sample, an arterial sample, or a line sample, typically there's some residual air in the syringe, and that has to be removed very quickly. Improper specimen mixing with heparin, and I will discuss that in detail. This is the key and critical point for preventing microclots. Heparin type and concentration, post-draw metabolism, as I've mentioned earlier, storage and transport considerations, and inadequate catheter flush. Air contamination. So the first challenge is bubbles, air bubbles. Look at this. Exposure to room air for 10 to 30 seconds can cause significant alterations in blood gas values, particularly PO2. The magnitude of error in PO2 is unpredictable. It can be either positive or negative. The room air PO2 is approximately 150 to 155 millimeters of mercury, or about 20 kilopascals. So if a sample has a very low PO2, say the patient's PO2 is 50, and it's contaminated with air, the result will be a higher PO2 than the patient actually has. On the other end of the spectrum, say the patient has an actual PO2, say it's an ECMO patient, has a PO2 of 300 millimeters of mercury, and it has an air bubble in it, then the resulting value will have a low PO2 in comparison to what the actual PO2 is. So some contributing factors: air volume to blood volume ratio. Obviously, the bigger the bubble of air compared to the blood, the greater the potential for air contamination. The number and size of bubbles, it's a surface area effect. A frothy sample with small bubbles presents more surface area for gas exchange. So that will have a more profound effect than a bubble of the same volume, but a single bubble. Time of exposure, obviously, the longer the bubble is exposed to the sample, the greater the potential for air contamination. Sample temperature, iced versus non-iced. As I'd mentioned earlier, icing samples is no longer recommended. And the reason for that is we know that hemoglobin has a greater affinity for oxygen at lower temperatures. And we say, well, that's not a big deal. It's in a syringe. It shouldn't be affected by that. Well, we have also found that polypropylene syringes are porous to oxygen. So when placed in an ice slurry, oxygen freely enters the syringe. And by virtue of the fact that there's a higher affinity for oxygen at lower temperatures, the hemoglobin will load up with oxygen from the ice water slurry. And then when the sample is analyzed at 37 degrees and heated to 37 degrees by the analyzer, that additional oxygen is released and we will report a higher PO2 than the patient actually has. Hemoglobin also has an effect. Hemoglobin is an oxygen buffer. So samples with low hemoglobin from an anemic patient are subject to greater PO2 changes because of the lack of buffering effect from the lower oxygen levels. So the solution, obviously, remove the air bubbles immediately after collection. So don't just draw the sample and hold the site and set the syringe down uncapped. Always, always, always remove the air bubble as soon as possible. Analyze the sample as soon as possible after collection. That reduces the potential for any air bubble contamination, and remove residual air and recap after analysis. So once a sample is analyzed, always remove the residual air and recap in the event that you would have to reanalyze due to error detection by the analyzer. Specimen mixing and heparin is the next challenge. Use lithium heparin formulations for electrolytes. Heparin binds sodium and ionized calcium. So heparin prevents but does not reverse clotting. Many people are not aware that heparin can only prevent clotting. So once a microclot is formed, no amount of mixing will reduce those microclots. Microscopic clots can form in as little as 10 seconds. What prevents clotting in the body is the blood being in contact with the vascular endothelium. So once a sample is removed from the body, the platelets kick into clotting mode and convert fibrinogen to fibrin, and microclots can form in as little as 10 seconds. Ensure the appropriate amount of heparin is used, and this is especially important for electrolyte readings. Too much heparin can alter sodium and ionized calcium. Sample mixing can affect results, especially hemoglobin and hematocrit. And in the solution slide, I'll show you the correct and recommended method for mixing. Appropriate technique in mixing can certainly reduce error. So use low or balanced heparin formulations if reporting electrolytes. Balanced heparin is heparin that has sodium and calcium added to the formulation to offset the binding from the sodium concentration. The final concentration of non-balanced heparin should be 20 IUs per milliliter. Do not use liquid sodium heparin for electrolytes. Two problems there. The sodium in the sodium heparin will alter the sodium value, and sodium heparin, liquid sodium heparin, has a very low pH, as low as 6.5. Use correct syringe size and fill to greater than 50% of capacity for electrolytes. And some manufacturers claim that you don't have to fill the syringe to more than 50% of capacity. So please read the inserts on your syringes. This is particularly important for neonatal applications when you're using 1 ml syringes. To avoid clots, mix a sample immediately after the draw while holding the puncture site. Again, do not set the syringe down because microclots, as noted, can start to form within 10 seconds. Or 3 ml syringe, the recommended mixing is to use a rocking motion for 30 seconds using 1 to 2 inversions per second. And that will adequately mix the heparin with the sample. It's immediate and at least 30 seconds of rocking to adequately mix the heparin with the sample to prevent microclot formation. 1 ml syringes don't mix as well, so they may require a longer and more vigorous rocking. Remix immediately before sample analysis. This helps to assure good hemoglobin hematocrit accuracy. If you're delayed in running the sample after the draw, a longer remix time before analysis. 1 ml syringes require a longer mix time for delayed analysis. And this is very important. Expel the syringe hub volume prior to sampling. That syringe hub, the blood in that syringe hub, did not mix as well with the heparin and tends to form microclots. And this is particularly true for line draws because no matter how well we clean the hub off the draw valve or the stopcock, there is potential for debris to settle into the hub, and then that can be transferred to the analyzer. Post-collection metabolism. As noted earlier, blood cells continue to metabolize after draw. White cells consume glucose and oxygen and produced CO2 and hydrogen ion as waste products, whereas red cells consume glucose and produce lactate and hydrogen ion as waste products. Blood gases, electrolytes, glucose, and lactate values will all change due to metabolism. So the greater the delay, the greater potential for metabolic changes. Ambient temperature as well. The higher the temperature, the greater the change. And this is something that's not well known. High white blood cell counts. White blood cells are very active oxidative metabolizers. So samples that have greater than 100,000 milliliters, as we often see in cancer patients, can rapidly decrease PO2. So the solutions: analyze the sample as soon as possible after collection. Keep the sample at appropriate temperatures. Now, these recommendations come from CLSI, Clinical Laboratory Standards Institute. For capillary samples and best results, measure within 0 to 10 minutes for capillary and best PO2 results. So if you're in a pulmonary function lab and doing shunt studies, the 100% FiO2 sample, analyze it as soon as possible because the metabolism will start reducing that PO2. For most samples, measure within 0 to 30 minutes, and again, sooner is better. Room temperature is fine. If there's going to be a delay, say it's coming from a remote site, 30, 60 minutes anticipated delay, ice water slurry, but the values will be altered from the ice water slurry. Greater than 60 minutes, either do not report or report with comment, and measure immediately if it's 100,000 white count or greater. Inadequate catheter flush. As mentioned earlier, lines have an infusion solution to keep the line patent. And if the line is contaminated or if the sample is contaminated with the infusion solution, it will definitely alter the values that are reported. So flush arterial and venous catheters adequately prior to sampling. Appropriate discard volume is dependent upon dead space volume of the catheter. So in other words, 2 mLs might be sufficient for some catheters, whereas others might take 4 mLs. The recommendation from a study that was published in 2003 is that if discarding twice the dead space volume will ensure pre-analytic quality. The dead space is from the catheter where it enters the artery to the draw valve. And very often the kit insert will show how much dead space is in that. If you don't have that available, one of the things we learned at my hospital was that you could estimate dead space volume by attaching the waste syringe to the port, drawing the solution through. Initially, it's clear because it's infusion solution. And then just past the hub, it starts to tinge with the blood. Once it is a consistent color and opacity, check the plunger volume and say it's 2 mLs, that tells you that you have cleared the dead space. Then multiply that by 2, which would be 4 mLs, would adequately clear the dead space volume in infusion solution. Capillary sampling is always a challenge. Squeezing a puncture site can accelerate clot formation by introducing venous blood, tissue fluid, and tissue clotting factor. Delayed or inadequate mixing can cause microclot formation. Skin cleansers that are used to reduce infection at the draw site can alter electrolyte values if they're not removed adequately. Alcohol-based or ethanol-based skin cleansers can reduce pH. Chlorhexidine and other cleansers can alter electrolyte values. Another practice sometimes used in neonatal units when draws are taken from umbilical lines is they'll draw a sample in a syringe and then transfer it to capillary to reduce blood loss. If this is done, you should use low heparin syringes or balanced heparin syringes along with low heparin or balanced heparin capillary tubes to reduce the potential for electrolyte alteration from the high heparin concentration. So pre-warm the capillary site at both hospitals I worked at. We used chemical packs to pre-warm the site. Pre-warming the site can increase blood flow by up to 7 times, and the capillary results will more adequately reflect those of arterial values when there's good free-flowing blood, because capillary blood is not arterial. It's a mixture of capillary, arterial, venous blood, and interstitial fluid. And it's much easier to obtain that sample. Remove excessive residual skin cleanser, as mentioned. Tilt the capillary tube slightly downward during the draw. This helps gravity and capillary action fill the tube. Use completely filled air-free tubes with sealed ends. Mix immediately, and again, this is extremely important. Do not set that tube down. Once it's capped, mix it by rolling the tube. The heparin is embedded in the inner surface of the capillary tube, and by rolling that tube, it mixes the heparin with the sample and will greatly reduce microclot formation. Remix prior to analysis and analyze the sample within 10 minutes, and sooner is even better. Other sources of pre-analytic error: not achieving steady state for sample collection. A 20 to 30 minute wait is recommended for changes in ventilator, positive and expiratory pressure, CPAP, or supplementary oxygen changes for the lungs and heart to equilibrate to those changes. Pneumatic tube transport of blood gas samples can change blood gas and potassium results. Pneumatic tubes are subatmospheric in pressure. As mentioned earlier, those blood gas syringes are not completely solid, and they do allow molecular passage of gases. So when a blood gas syringe is sent through a pneumatic tube, that blood gas syringe is exposed to lower pressures, and it can alter particularly the PCO2 and PO2. If ionized calcium is being measured and vacuutiners are used, they need to be completely filled. Otherwise, the PCO2 value will decrease due to PCO2 or CO2 loss to the airspace, which increases the pH and falsely lowers the ionized calcium. At higher pH, blood proteins have greater affinity for calcium. So the tube should be filled completely. So in review, ensuring pre-analytical quality and result accuracy. Was there error in the sample? Number 1, was the sample mixed immediately with a rocking motion for a minimum of 30 seconds and remixed before analysis with the first drop expelled? Was the sample transported correctly? Any delay? Was ice or room temperature transportation used? Should the sample be invested for contamination, such as line infusion solution? For electrolytes, was the syringe filled to greater than 50% of capacity as recommended by the manufacturer? Are there other factors affecting blood gas results? And finally, special precautions with aqueous controls. Most blood gas controls are aqueous. Aqueous control values can change due to handling. Control products are much more sensitive to handling than blood samples. So there are temperature issues as well as air exposure issues. So both should be, ampule temperature should be very close to what the manufacturer recommends, and minimum time should be there from opening the ampule to analysis. And with that, I would thank you for your time and participation, and we'll open it up to questions. Thank you.
Thank you,
so
John.
much.
That was very great. And go ahead, Abdullah.
No, I was going to say Mr. Tariq now. He will take over. Yeah. Please go ahead. Go ahead, Mr. Tariq.
That's a great presentation. I really appreciate it. There's a lot of, obviously, there's a lot of great information, and especially the style of the challenges and what's the suggested actions. Before I open the many amazing questions that we have that I reviewed, it just struck my attention, John, that what I noticed in your earlier data reporting from the analytical error, that it's particularly the three notorious parameters, that the pH, PCO2, the PO2, seems to take the highest level of sensitivity for the pre-analytical error. Is that because of the pressures mostly? And obviously the pH is affected with the CO2, but
well,
it seems, yeah,
Mr. Tariq, in regard to that, that was the Microclot study I believe you're referring to, and it's thought it's by virtue of the way the sensors are arranged on the sample pathway. pH is first, or PO2 is first, then pH, and then PCO2, I believe. And then it's thought that the microclots settle on the first sensors in the sample pathway.
Okay, I got you.
That's a very good point, sir.
Yes, that's under the same similar question. Mr. Muhammad Al-Hassan has a lot of great questions, but one of the interesting questions, John, does the barometric pressure affect the sample as far as, I guess, if we have, or does it calibrate against it, sea level versus higher than that?
The GEM 5000 has the pouches that hold the process control solutions are at zero head pressure, and barometric pressure does not affect it. And we've tested these up to 10,000 feet in altitude, and there's no effect of barometric pressure. As you know, at 10,000 feet, barometric pressure would be quite a bit lower.
Okay. Well, that's good. Another question, John, that's an anonymous attendee, but I thought it was a good question. Sometimes in some of the practices, they are having to transfer after collecting the blood from the patient, whether it's from the line, I guess, or directly from the stick. I know that some hospitals or some centers or even some labs, they have a practice where they are transferring the blood from that heparinized syringe to a capillary tube. I guess it's for ease of running, or
yes.
So the question is there any difference would you think that this may impact the results or accuracy?
Yes, it can. And there are two things that can affect it. If it introduces air bubbles, it will primarily affect the PO2. The other effect is the heparin effect. So if, say, for example, you're using a syringe with 150 IUs, or international units of heparin, and transferring it to a capillary tube with 150 IUs per ml, it concentrates the heparin and has potential to reduce sodium and ionized calcium. So if that practice is in place, it is really best to use a low heparin syringe and a low heparin or balanced heparin capillary tube. So that's indeed what we have recommended to several hospitals in the US that have noted that issue when they do that it alters those values. Another thing that's not widely known regarding electrolytes, and it's not exactly a pre-analytic issue, but in comparing blood gas, particularly sodium results, with laboratory core instruments, sometimes there's quite a bit of difference. And it turns out that, blood gas analyzers use what we call direct ion specific electrodes, so the sample's not diluted. Whereas in laboratory instruments, the vast majority of laboratory analyzers use indirect analysis, which uses a dilutional method and uses a fixed value for protein and lipid. So if the patient's sample does not have, I think 7% is what they use. If it's not protein and lipid values, not 7%, then the laboratory instrument will be in error, and the blood gas analyzer will have the more accurate result since it's not diluted. So if you wish, I will send some papers on that to Abdulla, and he can then forward that to you. It's very important and very much underappreciated. I could do a whole seminar on that.
Yeah, there was a few questions actually from the audience about this particular point, which talks about the differences of the lab and the blood gas. And I, as a clinician, usually as a respiratory, what we notice with some of the physicians, or they tend to run both because it's a hospital policy or whatever. And sometimes there is a tendency to sort of a pick of whatever the result that is usually that are preferred, or sometimes they will find they don't take the blood gas for sodium, but they will take it for the potassium, and vice versa for the others. And these particular ways of describing these are very important about the pre-analytical error.
It's particularly true. Excuse me, just one second.
Yeah, go ahead.
I'll make a point here, then I'll let you. It's particularly true in neonates because newborns have a very low protein level. And I had an excellent paper that shows many newborns have been inappropriately treated based upon the indirect methodology. And it looks like they have normal sodium levels when they're actually very hyponatremic. So I will send those papers to Abdulla, and he can forward to you if that's all right.
That's okay. That's absolutely good. John, another question I thought more interesting related to the pre-analytical regarding the CRRT samples, the CICA ionized calcium samples. Yes. What is the appropriate, in your opinion, the appropriate anticoagulant, since the citrate calcium is also an anticoagulant?
We have done some studies on that, and citrate, as you know, chelates calcium. And we have found that either citrate or heparin, we know the gems are quite accurate at very low levels, as we see in CRTT. So either one will work, and you'll get an accurate value. And we're starting to see in the US, patients who are on extracorporeal life support, we're, especially with the COVID crisis, that, due to all the problems with heparin and thrombocytopenia, that some centers are beginning to use citrate and trying citrate for some of those patients rather than continuing to heparinize the circuit. So the results are not out on those studies, but that's just started.
Okay, another quick question, John. If we run a blood gas and run into some issues or whatever from the analyzer, and then some errors detected, then had to do a rerun again, would you think that the coax reporting would be affected or accurate or not at this situation?
As long as the sample is remixed, and remixed well, the coax should be accurate. Now, having said that, the way the gem works is that it has a library of expected absorbance values for coax symmetry. Occasionally, you will get multiple errors on repeated samples in coax symmetry. Most of those samples, as we have found, have been variant hemoglobins. In other words, hemoglobins that are not this typical HbA. Sometimes sickle cell anemia hemoglobin will have those effects. There have been over 1,000 variant hemoglobins identified, and we know that some of those hemoglobins will give very bizarre results, and that's when you'll see an incalculable or an absorbance error on the gem. Another source of error is propofol induction. Propofol uses a lipid as a carrier, and if a sample is drawn right after propofol anesthetic induction, sometimes the lipid level is higher than the 2,000 milligrams per DL, and then it will cause absorbance errors on the co-oximetry. We've encountered this in several hospitals in North America, and the recommendation has been to wait 4 to 5 minutes after propofol induction for drawing a sample. And that way the lipid from the propofol itself has had chance to redistribute throughout the body, and it reduces the final lipid concentration.
Awesome. And I'll go back to your first part of answering this question, because there was a quick question. What did you mean specifically about long mixing? Does that mean longer time, or
yes,
that was one of the questions?
We're all very busy in hospitals. So say you draw a sample and then somebody calls you over because a patient is disconnected from a ventilator, and you go over and take care of that patient. The longer that sample sits without movement, the hemoglobin settles out. Blood is a colloidal, what's called a colloidal dispersion, and will settle very rapidly, particularly if a patient has an inflammatory process. We know that patients with sepsis, COVID, and other inflammatory processes, even pneumonia, the blood settles out much faster. So to get accurate results, and if there's any delay, you need to remix that blood longer to get a better hemoglobin hematocrit value. Good question.
That's very good. That's very good. One of the very common questions, I know that you've commented on it, and it's one of those things that are having sort of an evolution of the blood gas processing. But one of the, Mr. Fouad Hassan, one of the attendees, asking if we transport the sample without icepack, will that affect the result or not?
As noted, the recommendation by CLSI is if it's within 30 minutes, the results will not be affected very much at all, clinically insignificant. The exception to that is the high white count due to the high oxidative metabolic rate of white cells. Platelets also. So if you got a patient with an extremely high platelet count or extremely high white count, as sometimes we see in blood cancer patients. So beware if you work in a cancer hospital of those rates. And one of the things that I've done to troubleshoot is I've gotten calls that say, hey, these PO2 results don't make any sense on this patient. The patient doesn't look like they've got a PO2 of 50. And that's what we get, but sometimes it's 90 and we just don't know what's going on. And then almost universally, I'll say, what is the white count? And they'll check the white count, and it's in excess of 100,000. So that change that occurred to that PO2 was due to the very high metabolic rate of the white cells, the oxidative metabolic rate of the high concentration of white cells.
Okay, yeah, and along the line of this, there is another interesting case that also we've run into. I'm sure you've came across to it. Perhaps it's a bit more complex. It's another cancer patient who has what is known as a tumorlysis syndrome, where the white blood cells are, as you mentioned, are all over the place. And then his potassium analysis in the blood gas versus the analysis in the serum and in the lab is totally different. Like we're talking, it's about 3.1, and it's about 15 or 12 in the serum. And this is one of the rare cases that we actually have to depend on the blood gases. And this was pure medically justified by the physicians.
Yeah, I can comment upon that. Patients with that syndrome, the white cells in particular, tend to lyse under mechanical abrasion, as we see in centrifugation. So to get, or even letting the sample settle out. So if it's centrifuged, that will cause it. And just drawing through a vacutainer is different than drawing with a blood gas syringe. That's enough force on the cells to lyse them because they're very fragile. And that's another thing about icing as well. It is, especially with icing samples and sending them via a pneumatic tube, icing samples or blood cells makes the membranes much more fragile, particularly if there's a pathology in the white cells. And then sending that sample, drawing it with the vacutainer, then placing it at ice if that's what they do, or just sending it via pneumatic tube in particular will greatly increase the potassium due to lysis.
Okay, that's great. A couple of few more great questions actually regarding, again, back to the mixing. That's a good question actually from Mr. Saleh, one of the attendees. He's asking, does the automatic router or mixer for blood samples do the job instead of us trying to do the rocking versus the long mixing?
Yeah, that's an issue. By the time you get the syringe to where the mixer is, the microclots will already form. It's the immediate mixing. It's the immediate mixing that helps prevent microclot formation. So if you just draw the sample and take it back to the lab and then use the automatic mixer, that will improve the hemoglobin hematocrit, can improve the hemoglobin hematocrit level. But if you just follow those mixing guidelines initially and then right before analysis, the hemoglobin hematocrit is very accurate. It's very accurate.
Well, one more question. Does hypothermia, from Maria Makaslam, does hypothermia and hyperthermia affect blood gas results? And I maybe another spin to that same question. What's the significance, John, of reporting the temperature before analyzing the blood gas?
Oh my, this could take up a whole day.
Yeah.
Here's the thing. Reference values are at 37. There are no reference values for 35 or 39 or 36. So if you report a temperature corrected or adjusted value and then interpret it relative to euthermic or 37 degrees, then you are automatically making a mistake in interpreting that blood gas. Now, having said that, we're treating more patients with hypothermic methodologies now, and the alpha and method and pH method for temperature versus non-temperature corrected blood gases is being advocated when temperatures fall below a certain level. And it's beyond the time that we have for this discussion, but if you are reporting temperature adjusted values, you also need to report the non-adjusted values. So that's where the interpretation should be made. The whole purpose with temperature correcting blood gases, it relates to the PCO2 levels and how it affects carotid and cerebral blood flow. So that's, I think, and again, that's something I can send to Abdulla. I wrote up a very brief explanation of that. It's a Word document, and even I can understand it. So hopefully it can be useful. So I'll send that as well.
Okay.
And I'm available for follow-up questions that can come on this too.
Absolutely. Actually, yeah, that was great. Thank you very much, John. I appreciate that. That was sort of the summary of all this great interaction of questions, great presentation. I really appreciate it, and thank you. And I hand this over to our colleagues, Mr. Abdulla, and if for you also, John, if you want to close out before the end. Thank you.
I can stay.
Ladies and gentlemen, thank you all. It was a pleasure having you in this evening's lovely meeting. And on behalf of Abdulla Fouad Medical Company, I would like to thank you all for your attendance and your attention. And our extended thanks to our moderator, Mr. Tariq, and our speaker, Mr. John. Hopefully, we have enlightened your practice a little bit more with this informative session. Thank you all. Please be informed that this won't be our last meeting. We have a very rich schedule till the end of the year. Till our next meeting, I encourage you all to visit warfinacademy.com for more information and for more sessions. Until we meet again, enjoy the rest of your evening and Eid Saeed in advance. See you again, inshallah, very soon. And in case if you need any more information, we will be online for you. Warfin Academy, you can send us an email or whatever you need to ask. Feel free to. And thank you again. Enjoy the rest of your evening.
Thank you so much, everyone.
Thank you.
Thank you, John. Thank you,
Bye-bye.
Muhammad. Thank you, Abdullah. Thank you.
Thank you, Tarek. Thank you, John.
You're welcome.
Bye-bye.